Spring is in the air like a drum snare. Buds are bursting, beautiful green. It's like a love scene with waves of flirting. Seasons change us. Maybe it's just me and mine, where thunder has had its way. When kindness is portrayed as blind and glitter to the rays. Oh, no need to beg pardon. No need to beg pardon. Strong piano playing, wind chimes swaying. I'm longing for summer nights down by the ocean. High emotion, legs covered in mosquito bites. Oh, seasons change us. Maybe it's just me and mine, where thunder has had its way. When kindness is portrayed as blind and glitter to the rays. Oh, no need to beg pardon. No need to beg pardon from me. Maybe it's just me and mine, where thunder has had its way. When kindness is portrayed as blind and glitter to the rays. Oh, no need to beg pardon. Oh, no need to beg pardon. Oh, maybe it's just me and mine, where thunder has had its way. When kindness is portrayed as blind and glitter to the rays. Oh, no need to beg pardon. Oh, no need to beg pardon.
Thank you all so much for joining. We'll give it another 2 or 3 minutes to let some other people join up, and then we'll get the presentation started. Thank you so much.
Hey there, buddy, are you doing all right? I'm doing great, as a matter of fact. I'm on the road. Yeah, yeah, yeah. The bad days are gone, and now
Good morning and good afternoon, and welcome. Thank you all for joining us today for patient ventilator dysynchronies and their mechanisms, brought to you by Medtronic and the Professional Affairs and Clinical Education, or the PACE group here at Medtronic. I'm stepping in for my coworker, Fernando, who is receiving a great award today. And so I'm just kind of pinch hitting today. So please forgive me for any strange technical challenges that we may have. But we'd like to get started and introduce our discussion today, which, as you all know, is patient ventilator dysynchronies and their mechanisms. We are also offering the typical CEs for this from the California Board of Nursing, the American Association for Respiratory Care, and the AANA Type B credits, as well as for EMT. That information will be sent to you all about an hour following the presentation. There are a couple of housekeeping items. First off, there is translation available for this. There should be an interpretation button at the bottom of your screen for English, Portuguese, or Spanish. Clearly, I will be speaking English today. I have two translators who will be helping out with the others. And if you have questions, there is a Q&A at the bottom of your screen where you can type in your questions for the panelists, so that at the conclusion of the presentation, Dr. Laurent Burchard and Dr. Ilya Teles will be able to answer some of these questions for us. So without further ado, let me introduce Professor Laurent Burchard. He's the director of Interdepartmental Division of Critical Care Medicine at the University of Toronto. He is also the Keenan Chair in Acute Respiratory Failure and Critical Care Medicine at St. Michael's Hospital, where he's also leading a Center of Excellence in Mechanical Ventilation. In addition, Dr. Irene Telias is an intensivist from Buenos Aires, and she is currently conducting research in Toronto with Dr. Burchard, and she joins us to answer some of the questions at the conclusion of this. Without further ado, I will turn this on over to Dr. Burchard.
Thank you for the introduction. It's my great pleasure to be in this meeting, which is a virtual meeting, and to discuss the fascinating and complex issue of patient ventilator dysynchrony, how to understand their mechanism and then to manage these dysynchronies. This session is sponsored by Medtronic, and I'm receiving funding for this presentation, but I'm responsible for all content. And these are the medical disclaimers. My laboratory has also received a research grant or equipment for different research studies, and they are listed here. So some of you, maybe not all of you, will remember that not so long ago, this is how an ICU ventilator was looking like. We were looking at numbers and at needles, and that's all we knew about the way ventilation was delivered to the patient. Nowadays, and this is not the most up-to-date photograph of the ventilator, and I'm not going to present one ventilator more than the other, but just to show that one of the main characteristics of ICU ventilator is that they all display on a screen the waveforms of the pressure, flow, volume, which tell us a lot about the interaction between the patient and the ventilator. And surprisingly, these waveforms are really, I would say, for eyes only, because we have to analyze these waveforms. So they tell us a lot of things, but until now, most ventilators do not really analyze these waveforms. And I will show you that you can get a lot of information and maybe understand things which can be important to better manage the patients. So I'm going to discuss synchrony, and the idea of synchrony is that the ventilator is assisting the patient exactly at the good time. That's what is synchrony. So if you think that the patient's effort, which is assessed by the negative swings in intrathoracic pressure, in esophageal pressure, a ventilator working in good synchrony would start at the time the patient effort is starting and terminate during the relaxation. So that would be a very good synchrony between the patient and the ventilator. But we don't have esophageal pressure usually, most of the time. So what we have is this, and plus the other curves, and especially the flow time curve, which I will discuss. So we have to guess from these curves whether there is a good synchrony or not, and try to think about why it could matter that the synchrony is more or less good. So that's a list of very general statements. Most of the ICU patients are under ventilatory assist. They are assisted by the ventilator. It's a partial assistance. And this assistance is supposed to be synchronous. And keep in mind that the sedation which is given to patient is most of the time given to adapt the patient to ventilator and to avoid desynchrony. We know also that desynchrony is associated with longer duration of ventilation and higher mortality. I will show you some data. And what the purpose of my presentation is to say, well, part of this association may be mediated by inadequate sedation, inadequate ventilatory settings, so we can probably do a better job. In addition, it's very important to understand that this asynchrony, and I will insist on the fact that there are very different types of asynchrony, are also related to the adequacy of ventilation delivered. When we have a patient under ventilatory partial assist, what we would like is to have the patient developing a normal work of breathing. If the patient is not receiving enough support, so which means working too much, the patient will develop respiratory distress and maybe injury to the muscles. But we know and we are aware that there are a lot of risks associated with excessive dose of support, with ventilator-induced lung injury, ventilator-associated lung injury, and ventilator-induced diaphragm dysfunction. And what's interesting in the understanding of asynchrony is that you have some asynchrony associated with excessive dose of support, and some asynchrony associated with insufficient dose of support. And when I say excessive or insufficient, I mean related to the needs of the patients, which can be, of course, modulated by the degree of sedation. So this is complex, but this is what we need to figure out at the bedside, right? Are we on one side or the other? Are we giving too much support or maybe not enough sedation, etc.? And interestingly, if you think this way, the relationship between dysfunction and dose of ventilatory support, you could think the other way, which is the respiratory drive. So in some asynchrony will be related to a very high respiratory drive, so insufficient support compared to the need of the patients, whereas other asynchrony will be related to a very low respiratory drive because we give too much support. I'm saying that because I will show you that assessing the drive of the patient can be very helpful to understand the type of asynchrony and how to manage it. So there are three situations really. The situations where the patient is fully sedated, so there is no apparent respiratory drive. In this situation, there is a specific asynchrony called reverse triggering, which can exist with or without breast stacking, and which may be difficult to differentiate from the classical breast stacking. I will discuss that. Then you have the second situation where there is respiratory drive, but it's excessively low. So because the patient is doing very little effort, and that can be because you give too much ventilation or too much sedation. And the asynchrony in this category correspond to prolonged cycle during pressure support, apneas during pressure support, and ineffective inspiratory efforts. It has been shown that very often it occurs in clusters, probably corresponding to certain level of very low respiratory drive. And then at the opposite, you have the situation where the respiratory drive of the patient is high, which means the ventilation is relatively insufficient compared to the needs of the patient. And it can be insufficient in terms of volume, in terms of flow, in terms of time. And this induces what we call the short cycles during pressure support or during assist control, with or without double triggering and breast stacking, and also flow starvation. Okay, so 3 different situations, 3 different mechanisms, and 3 different types of desynchrony. Therefore, if you see something weird on the ventilator, on the waveforms, and you say, oh, there's some kind of desynchrony, I think you have kind of 3-step approach. One is to understand the type of desynchrony and the mechanism, then to adjust the ventilatory settings specific to the mode and to the asynchrony, and then ask the question, do I need to modify the respiratory drive, which always can be done by either changing ventilation or sedation. Okay, there are many different consequences of asynchrony. I'm not going to go into all the details. And again, because it depends on the type of asynchrony. As I said, it can indicate excessive or insufficient ventilatory assistance. It can be associated with dynamic hyperinflation, with too much sedation or insufficient sedation. I will show an example where it's associated with sleep fragmentation. It can induce errors in assessing weaning readiness, and it can be associated with prolonged duration of ventilation and probably respiratory sequelae. So again, the literature show repeatedly that the duration of ventilation is longer in patients who have a lot of asynchrony. The mortality even seems to be higher. And there is especially an important impact when asynchrony occur in clusters. So for instance, during 3 minutes, you have a lot of asynchrony, and that type of event seems to be especially associated with longer duration of ventilation and worse outcome. Detecting the asynchrony, as I said, can be done on flow and pressure, but there are specific tools which can help. But of course, these tools are usually not available all the time. So this is the example of having an electrical activity of the diaphragm. And of course, when you have that, it's easier to see that the diaphragm is working completely desynchronous with the vent, because there is an activity of the diaphragm which is not resulting in a breath delivered by the patient. So this would be an ineffective effort. And another signal which you can get is the esophageal pressure. This is the esophageal pressure during passive ventilation. This is during active ventilation. So if you can have on the same screen the airway pressure, flow, and esophageal pressure, again, it will facilitate the detection of this asynchrony. But most of the time, we don't have these signals. Hopefully, in the near future, we should have ventilators able to detect this asynchrony without any additional signal. I'm showing publications which are not related to a specific ventilator, but showing that it's absolutely possible from the analysis of airway pressure, flow, and volume to detect most of the asynchrony. These are different types of works, and I'm sure in the future the ventilators will start to do that, to analyze this, what the patient is really doing. But for the moment, it's not yet available. I mentioned briefly that the respiratory drive is an important feature which can help you to detect the type of asynchrony, let's say the circumstance in which the patient is having asynchrony. And one very interesting tool which is now available on all ventilators is the P01, the occlusion pressure of P.1. This is the pressure generated during an occlusion of 100 milliseconds, which, as you know, is probably about the same time than the triggering phase when you're triggering on pressure. And therefore, that's why it's so easy for ventilators to do this maneuver. So some ventilators display breath by breath, others prefer to do a maneuver, which will be more carefully performed maybe. But in any case, it can tell you, especially if it's below 1 centimeters of water, it really tells you the drive is too low. And if it's above 3.5 or 4 centimeters of water, it tells you that the drive of the patient is very high. Okay, let's go now to the different specific types of asynchrony, which I mentioned briefly at the beginning, and try to understand how they develop and therefore how we can manage this asynchrony. So the first category would be, I start with the low drive, the assistance in excess. So the patient is not in high respiratory drive. It may be, he or she may be with very low respiratory drive. And in these categories, I will mention briefly auto-triggering. And then you have apneas and ineffective effort or missed cycles. So auto-triggering, as you know, is a situation where the ventilator detects a signal which it does not come from the patient. So it can be a leak in the system, and a very small leak can induce auto-triggering. It's very, very frequent during non-invasive ventilation, even if we don't see it. Every time we analyze recordings under non-invasive ventilation, we see a lot. And the concern is to be sure we don't miss it when the patient is supposed to be on protective ventilation. For instance, this is a nice example of a patient under SIMV, and you see that the cardiac oscillation were triggering every other breath. So you had the mandatory breath and then the breath triggered by the cardiac oscillation. And it's only by changing the trigger sensitivity that this auto-cycling were suppressed. That can be really very difficult to detect, and you may think about it if you're surprised by a high respiratory rate or low PCO2. Then there is this big question of patients ventilated under partial assist, especially pressure support, but that could be another mode of ventilation, with excessive ventilation. And unfortunately, this is very easy to hyperventilate the patients in pressure support ventilation. And you could say, well, maybe that does not matter so much, but you know, one reason we don't want patients to have their respiratory muscle completely inactive is that it can induce diaphragmatic atrophy very quickly. And you can see on the first paper, for instance, here is one of the many experimental studies which show that with high level pressure support, you can do exactly the same thing that control ventilation and induce diaphragm atrophy and diaphragm dysfunction. And therefore, it becomes necessary to be able to make the diagnosis of over assistance during pressure support, because this is a really frequent problem. Let me show you a nice example. This is tracings where you have the flow, the airway pressure, the volume, everything looks very regular. But in this case, we also recorded the transdiaphragmatic pressure and the diaphragm EMG. And what you see is that if you look, for instance, at these breaths, this is the pressure generated by the diaphragm. You don't see very well, but the scale indicates it's a very low pressure. So the patient is doing a very small effort. And if you look at the EMG activities, so this is this kind of big burst on top of the ECG, you see it happens only at the triggering phase. So in terms of synchrony, all the insufflation, and this is pressure support ventilation, all the insufflation is passive, is controlled ventilation. So you think your patient is on pressure support and breathing spontaneously. In fact, your patient is essentially on pressure control ventilation. And what will happen next is the occurrence of apnea. And this will happen very quickly if the patient is asleep or is trying to sleep. Because during sleep, we don't keep a respiratory rate, we go into apnea. When you're awake, you always keep a certain respiratory rate. But as soon as you go to sleep, you may develop apnea. This is characteristic of sleep. And because of the slight hyperventilation, these patients will go into apnea. And this was a very important study by Sai Parthasarathi and Martin Tobin. They showed that by analyzing the sleep characteristics in patients on pressure support, you see this repeated episode of apnea. If you look at the tidal volume tracing, for instance, all these apnea episodes were followed by episode of arousal or even awakenings. What does it mean? It means that you have apnea, you are a patient, you're trying to sleep, you have an apnea because you are hyperventilated, and then you have an arousal. And that's continuously 24/7. So this is a cause of sleep deprivation. This is very, very bad. So every time you see a patient becoming apneic with the low minute alarm, ventilation alarm on the ventilator, it means that this is a iatrogenic complication. You're giving too much pressure support. So this is an important side effect of excessive pressure support. Another one is what we call ineffective efforts. Again, this is the tracing, airway pressure and flow, and we put here the esophageal pressure. And this is a patient with some degree of auto-PEEP or intrinsic PEEP. And you see with this intrinsic PEEP, there is the initial part of the effort, which is done before the ventilator can trigger the breath, okay? But the result is that most of the insufflation will take place, induce small deformation on the airway pressure and the flow. So this is where you can get it. But this will be causing a wasted effort or an ineffective breath. And the main reason is that the patient has been receiving too much pressure, too much volume, the breath before. So again, when you have the esophageal pressure, it's easy to detect. At the bedside, you don't have esophageal pressure, but most of you are probably aware of the fact that if you look carefully at the airway pressure or mostly at the flow signal, you can detect that the flow is not a perfect exponential decay, and these small encroachments in the flow signal indicate that the patients is trying to inspire. And this is most of the time caused by excessive level of support. Just to show at the bottom an example during assist control ventilation, so it's not specific to pressure support. I showed this example because this is from another type of screen. You see, sometimes it's not very easy to see. And on this patient, we add the electrical activity of the diaphragm. So now you recognize this, these two ineffective efforts. So what's important, and I told you at the beginning that the ventilators now are not analyzing these curves, so they will not tell you. So what you see on the screen of the ventilator, the respiratory rate of 18, is wrong. This is the respiratory rate of the ventilator, so it's true, but it's not the respiratory rate of the patient. The respiratory rate of the patient may be twice this value, maybe like around 35. So that's important to realize, because if you as a clinician decide to reduce the level of pressure support, for instance, because this is the cause of this asynchrony, this will markedly increase the respiratory rate displayed by the ventilator. And of course, it's important not to interpret that as a respiratory distress. In fact, we tested that in a study where we tried to see what's the best approach to eliminate these ineffective efforts. Is it to modify the PEEP level? Is it to decrease the pressure support, or decrease the inspiratory time by adjusting the expiratory flow settings? We were surprised to see that the PEEP did not work. Okay, maybe it could work over a certain range, but in our study, it did not make a difference. And what made the difference was to reduce pressure support, or to reduce the duration of the breath by increasing the expiratory flow sensitivity. And this was a small series of patients. We selected patients with a lot of asynchrony. You see asynchrony index, which is the total number of effort reported to the number of breaths, was around 50%. And in most of the patients, we were able to avoid these ineffective efforts. Not in all of the patients, which indicate that some ineffective efforts are simply related to the disease and the mechanics of the patients, but a lot is due to pressure support. And when we reduce pressure support, of course, we saw an increase in the respiratory rate displayed by the ventilator, but not the true respiratory rate of the patient, which did not change. And despite this apparent increase in rate, the work of breathing of the patient did not increase. So it was simply too much assistance, too much volume, causing these ineffective efforts. So just to summarize this part, low respiratory drive desynchrony with excessive assistance. I put here the patient is sleepy. Remember, this is not associated with a patient fighting the ventilator, okay? So ineffective efforts are mostly those you observe in patients who are hyperventilated and or maybe too much sedation. So very often your patient will look sleepy. Just by looking at the screen that you will see this ineffective effort. So it's associated with a low respiratory drive. If you measure the P01, it will be frequently below 1 centimeters of water. And I would say the number one thing you need to do is to reduce ventilation. So reduce pressure support level, maybe decrease your tidal volume and inspiratory time by increasing the expiratory threshold. And of course, if the patient is under sedation, you may discuss that the patient has too much sedation, and sometimes it comes from from analgesia, for instance. Okay, let's switch to a completely different situation, other types of asynchrony, where the patient is not receiving enough assistance related to his or her needs. And these are classical situations where you can have what has been called hair hunger or flow starvation. So the patient is not receiving enough flow compared to the demand of the patient. So this is not exactly what we call asynchrony, but that's the same mechanism. And the specific asynchrony can be double triggering, can induce sometimes breast stacking, and also the short cycles. So just remember, when we speak about volume control ventilation, this would be a passive breath. This is an active breath where the patient is triggering the ventilator. You see the negative pressure swings on esophageal pressure, some negative pressure on the airway pressure. And if you superimpose the two curves, and this is a characteristic of assist volume control ventilation. If you superimpose the two curves, the difference between the passive curve and the active curve is exactly the same quantity that superimposing the passive esophageal pressure curve and the active one. So it tells you how much the patient is working. So I'm saying that because every time you see a deformation on the airway pressure wave shape, it indicates that your patient is working. So during assist volume control ventilation, you can visually detect if the patient needs more flow, more volume, or more sedation because the patient has flow starvation or hair hunger. But in this situation, very often what you will see also is that the patient needs a longer duration of inspiratory time, insufflation. So these are two examples where you see that after the end of insufflation, the expiratory flow looks really abnormal. Instead of a peak expiratory flow and exponential decay, you have this W waveform, which indicates that, in fact, the patient is still doing inspiratory effort. And in fact, if you look at the esophageal pressure, that will be the esophageal pressure curve. So this is a typical of a short cycle. Okay, you don't see a normal peak expiratory flow. So it means the patient is continuing inspiratory effort after the end of insufflation. And of course, very often this situation will induce double triggering. Okay, you see the first breath completely stopped by patient's effort and triggering immediately of a second breath. So when does this happen? Well, this happens if you have small tidal volume, which now we tend to do all the time, and relatively short inspiratory time, which we also do frequently because we use relatively high flow during assist control. And high flow, small volume means short inspiratory time. You probably know these classical studies which show that one important parameter influencing the respiratory drive is the flow rate. The lower is the flow rate, the higher is the work of breathing of the patient. So this illustrates that for the clinician, this is a complicated situation, because if you want to increase the flow rate to decrease hair hunger and flow starvation, you will at the same time decrease the inspiratory time and make more likely that you have double triggering. So again, a complicated situation, but this can really put the patient into big troubles. this is I like this graph because this is coming from a study comparing two levels of PEEP. And after the end of the study, it's a big randomized trial performed in Brazil. They say, well, we never really controlled for desynchrony. And we realized that in some patients, this is a recording of a patient, there was a lot of desynchrony. And you see an example where you have the first breath trigger, the second breath trigger, and this happens very frequently. So it's a lot of double triggering. Well, inducing, in fact, of ventilating your patient with 6 ml per kilogram, the patient was ventilated with 12 ml per kilogram almost every other breath. So, and in addition, this is, as you can see on the last signal, which is the thoracic impedance signal, this inducing breath stacking. So it's the second breath on top of the other. And especially in the high PEEP group, well, maybe this created a lot of damage because you were really at very high level of lung volume. So paying attention to that is important and has been unfortunately ignored in most of the ventilation trials. Just to remember, but you know that this is different when you use pressure assist control or pressure support, because during pressure support, the pressure will not change like in assist control in volume. The pressure remains the same, so you do not have the same indications. And the only way in pressure control to know that your patient is working hard is to measure the P01. So again, these situations of high respiratory drive desynchrony related to insufficient assistance, in this case, by contrast to the preceding one, you will look at your patient, you will see that your patient is working hard using accessory muscle. If you measure the drive, you will see a high respiratory drive, maybe 4 centimeters of water or higher. And for the clinician, that's not very simple. You may try to increase the flow, but you may decrease the time. You may want to increase the PEEP, which can help. You can try to increase slightly the FiO2 to be sure your patient is not on the low side of saturation. And you can discuss whether it's possible to increase ventilation. So is it reasonable, for instance, to increase tidal volume? If you cannot, if the answer is no, the only solution is then to go back to more sedation and sometimes to paralysis. Okay, let's go to the third situation, which is a very interesting and fascinating one, which is a situation where the patient is under controlled ventilation. The patient is receiving sufficient sedation to suppress the apparent respiratory drive. The patient is not triggering the ventilator. Well, in this case, there is a frequent asynchrony called reverse triggering. I will show you why we call it like that, and which has been described as being respiratory entrainment, which is the fact that the ventilator is entraining the respiratory rhythm of the patient. So it came from an accidental observation. This was a patient on pressure control, and there was no indication that this patient was breathing spontaneously. If you look at the airway pressure signal, you see no triggering phase. And in these patients, we looked at the diaphragm electrical activity because we wanted to capture when the patient is waking up. And we were surprised to see that at every breath, there was a strong diaphragmatic contraction. When we look at the timing, the synchrony between the two, well, surprisingly, every diaphragmatic contraction happened after the beginning of the insufflation, very regularly. And when we modified the respiratory rate on the ventilator, it also modified the respiratory rate of diaphragmatic contraction. So this was not the patient triggering the ventilator. to the ventilator, triggering diaphragmatic contraction. That's why we called it reverse triggering. Not always easy to detect. So you see here, you can see slight changes in the airway pressure, but very difficult to detect. So we published that now a number of years ago, and since that time we have a lot of publications which increased our knowledge about this problem. So I showed you an example where it was at every breath. This is another example where it's like every other breath. So you see this is the esophageal pressure, you see a passive breath, then passive insufflation followed by a contraction. The next one is a passive breath. The next one is a passive insufflation followed by contraction, etc. What are the consequences? Well, for instance, if you are in pressure control, every time you will have this contraction, like here, you will increase your tidal volume. So you may result in larger volumes than expected. But you may also induce a second breath. Okay, so that's what we call double cycle. So it's not exactly double triggering because remember, the first breath is not triggered by the patient. So there is a mechanical insufflation followed by a diaphragmatic contraction, which trigger a second breath. Remember, these are sedated patients. So this is not a situation of a high respiratory drive. This is a situation of a very sedated patients with no apparent drive. And this is an example of patients. So you see these kind of tracings where, again, it's an ARDS, sedated, 6 ml per kilogram of predicted body weight. You have this double cycling, even triple. So instead of receiving 6, the patient here is receiving 12, and even 18 milliliters per kilogram. And if you look carefully, probably this is not double triggering as indicated here, but double cycling, because this is the reflex mechanism triggering a second breath. So completely different mechanism from double triggering. You remember, it's situation where patients have a high drive and you may need to give more sedation. In this case, this is completely different because the patient is already sedated. We did this study in patients who were intubated in the ICU, and at 24 hours for patients who were on assist control, we tried to detect how many patients had reverse triggering. So all these patients were under assist control. And this is for the 40 patients on assist control, the number of reverse triggered breaths expressed as a percentage of the mechanical insufflation. So we detected that by different methods, and the incidence vary depending on the sensitivity of the method. But we were surprised to see that it's a very large number of patients. If you detect very, very small values, it's almost all patients. So let's say that maybe something like 40% of the patients have at least some reverse triggering when they are under controlled ventilation. And when we compare patients with a high incidence versus a low incidence, the surprise was to see that patients with a lot of reverse triggering were patients who 24 hours later were usually under assisted mode, like pressure support, or even extubated. So what does it mean? It means that the reverse triggering probably is occurring when the patient starts to have some receptivity of the brain to start triggering the ventilator. So it's a kind of transition between very, very strong sedation and resuming spontaneous breathing. So that's important because if you see a patient with a lot of reverse triggering, maybe the simplest solution is to decrease or stop sedation so the patient will take control of the breathing pattern. This is a recent study which was performed in Argentina. So it was mostly done by the respiratory therapists there. They did recordings and in many centers, and they took patients with early ARDS. So this is their detection. You see again, you have this kind of short cycle, if you wish, because the expiratory flow is not normal, but this is mandatory breath. It's not triggered by the patient, and they have the evidence here with the esophageal pressure indicating this is a patient with a lot of reverse triggering. And this is the entrainment pattern. So whether it's every breath, 1/2 mandatory breaths, 1/3, so you have different patterns. We don't know why. And what was interesting was that this was associated with smaller tidal volume. So the smaller was the tidal volume, the more frequent was the incidence of reverse triggering, and was also inversely correlated with the amount of opioid sedation by fentanyl. So patients with small tidal volume and a little bit less sedation, they are more prone to develop this reverse triggering. And again, it may be time to stop sedation. This is a more recent study published in the Blue Journal. What was interesting in this study is that, they gave a number of examples. So it's not very easy to see, but they say there are different patterns. So this is the early reverse triggering, which is during the delayed relaxation. This is in the middle of the breath, and this is at the end of the breath, inducing breath stacking. So I'm showing this example because, for instance, in the second tracings, in the middle of the breath, most of the contraction of the diaphragm is during the expiratory phase, right? Because it's triggered after the insufflation. And maybe this is not good for the diaphragm, because this is at the time where the diaphragm is lengthening, and it's what's called an eccentric contraction. So we think that potentially when it's a high effort, it could induce injury to the diaphragm. And in fact, when you measure, this is a study we did, the amount of effort during reverse triggering compared to pressure support, it's about the same magnitude. And when it induces breath stacking, it's clearly associated with a higher level of effort, which potentially could be injurious. So very interesting and fascinating phenomenon. Seems to have very high incidence early after intubation in sedated patients. Many breaths are only small efforts, so maybe not terribly concerning, but higher efforts are at risk of double cycling, breath stacking, and potentially injurious for the diaphragm. And it seems to occur especially at the transition from deep sedation to resumption of spontaneous breathing. Excuse me. So this is important because sometimes clinicians may see that there is something weird happening on the ventilator at the time sedation starts to be stopped, and instead of waiting for the patient waking up, they give more sedation. And I think this is a wrong approach, because this will prolong the time of ventilation. So remember, these are patients sedated. You have no respiratory drive, no apparent respiratory drive. And what you can do is decrease sedation, or maybe sometime increase ventilation, because as I showed, it's associated with small tidal volume. So I will stop there. As you can see, this is a really fascinating field. It's important to understand the mechanism, because this is explaining why the dyssynchrony occur, and it is also explaining what we clinicians are doing in terms of ventilation compared to the patient's need. Sometimes it tells us, oh, we are giving too much ventilation, we are not giving enough ventilation, or we are giving too much sedation. So if you are interested by continuing to explore all these aspects, please visit our blog called coemv.ca. We do the blog with Tom Pireno, who is known to many of you, and we are happy to chat and discuss tracings and screenshot of complicated patients. Thank you very much for your attention.
Thank you, Dr. Burchard. So this is Danny. Once again, I'm kind of pinch hitting here for Fernando and the rest of the PACE team. And just based on the way that we had set up this presentation, I was unable to answer some of the questions or respond, in fact, to some of the private messages. So many apologies. I wasn't ignoring you. I was simply trying to ensure that we would be able to get through the presentation without any issues. Thank you all for attending. We do have Dr. Irene Telles here to answer some questions. And I do see that there are several questions in the queue, and I wanted to potentially read some of those out. I will start with some that I know that I can answer, and then I would ask the Dr. Telles would feel free to jump in with some of these other questions as they're more clinical in nature, and though I am a clinician, I feel that it would be more appropriate for someone else other than me to answer these questions. So in terms of handouts, typically following the presentation, about an hour afterwards, you will receive an email, or attendees will receive an email with attachments that may be both a video and may also include the presentation handouts. So fear not, that information will be coming your way at the conclusion of this, plus about an hour. In addition, you should see your CEs that will be available at that time as well. One of the first questions that we have, Dr. Elias, is does correction of dysynchrony necessarily reflect in ABG values?
Yeah, so thank you for that question. I think that ties up very nicely with Laurent's question that comes before about the fact that patients with too much ventilation support and dysynchrony, like those with prolonged cycling and ineffective efforts, frequently are alkalotic due to hyperventilation. So this is absolutely true, and this is very frequent in patients under pressure support that are recovering from their acute illness. So during pressure support, the tidal volume that we deliver depends on the amount of support that we're providing, interacting with the patient's respiratory system compliance and the patient's inspiratory effort. So if the patient's respiratory system compliance improves over time, then with very little amount of support, we're providing large tidal volumes. And their patients' metabolic demands also decrease. So it's very easy that the patients would become alkalotic with slightly lower CO2 levels due to this hyperventilation. So if you start looking at your ABGs of patients under pressure support, you will see that they frequently become very alkalotic. And this is exactly the situation when we start having asynchronies due to overassistance. So prolonged cycling and ineffective efforts. So that would definitely answer Laurent's question. So she's completely right. And then regarding the correction of dysynchrony, if the correction of dysynchronies will be reflected in the ABGs, I would say it depends on the mechanism of the dysynchrony. So if this is the condition, so dysynchrony in the context of very high overassistance and excessive support, then normally if we would correct the amount of support, so decrease the amount of support, the patient's CO2 will eventually rise, and then patient's inspiratory effort may increase, and then these ineffective efforts would become effective. So that might tie up well, but in the context of high drive and low assistance, usually the patient's ABGs are normal, or even they might also be a little bit alkalotic due to the high drive and effort. And the stimulus for the high drive and effort usually comes from other sources, not CO2 specifically. It's because their patients have severe lung injury, and then they're stimulus coming from the lungs, or maybe they're uncomfortable, and so anxiety and pain and discomfort might drive the increase in respiratory drive. So then the ABGs are not so useful in following the desynchronies. So I think that comes with this one. And then there was another question. I don't know if anyone has any question. No, follow up. There's someone asking a question in Portuguese about what to do if we cannot adjust the ventilatory parameters to correct reverse triggering. So reverse triggering is a very tricky asynchrony in terms of how to manage ventilator settings and how to manage the patient, because we have some insight of what's the mechanism of reverse triggering, but really it's very recent that we have started to understand how it works. So what I would say is whenever you have a patient with reverse triggering, you have to ask yourself two questions based on the current information we have. We are really working on trying to understand how reverse triggering works. So the first question would be if the patient has any drive or not. So patients with reverse triggering, you can perform a long end expiratory occlusion and then see if the patient would take a breath. If the patient would take a breath during this long end expiratory occlusion, it means that the patient has some respiratory drive. If the patient does not take any breath, then really the reverse triggering is a reflex contraction due to the insufflation provided by the vent. So if the patient has some intrinsic drive, then you have to ask yourself, is it safe for the patient to take over ventilation? So is the lung injury recovering, or is, in terms of, would it be safe if the patient takes control of ventilation? And then if yes, the way to go would be to really stop sedation and allow the patient to take over ventilation instead of the ventilator driving the patient's drive and effort. Because then once the patient takes over ventilation, it's much easier to control the amount of drive and effort that patient has. So that would answer that question. So there are a lot of questions coming. Then this other question, G is asking about if we can measure reverse triggering using EDI and esophageal pressure. Yeah, definitely. So that would be the way to go if you're not really sure about what's happening there. So if you put an esophageal catheter or if you have EDI monitoring, you will really see the inspiratory effort coming immediately after mechanical insufflation. She's asking about, asking about if there are studies showing this. So the two studies that, the three studies that Dr. Burchard referenced to in his presentation, so that our group in Toronto, led by Dr. Felipe Damiani, then Pablo Rodriguez study from Argentina, and Elias Cassis from Boston. The three of use either EDI or esophageal pressure to detect reverse triggering asynchrony. Let's see if there's anything else. I don't know, Wade, if you, sorry, Danny, if you found any. So there's here a question in Spanish. So when you have a hyperventilation, if this is caused by the ventilator or conditions relative to the patient's own intrinsic clinical state. So I would I would say both. Both situations can occur. So it can be either due to our excessive support or the patient's decrease in their, so maybe I would say it's the combination of the two. So it's the patient, so it's our excessive support as clinicians plus the patient's decrease in metabolic demands. So that combination would render excessive hyperventilation. When we refer to hyperventilation in this condition, we're not referring to the patient's high drive and excessive effort and hyperventilation. So that could be a tricky thing to understand, because when we say hyperventilation outside of this field of desynchronies, we refer to a patient that is really working hard and hyperventilator. hyperventilating. In this case, we are referring to us providing excessive support to someone whose metabolic needs are not so high. So I think this is an important concept to make clear. So
I know that we're about a minute over, but there are two questions regarding ARDS and PEEP. There's what is the best option to obtain best PEEP within asynchrony? But then there's also one regarding COVID and ARDS, and I wondered if you wanted to maybe take a look at those questions.
So regarding PEEP and desynchrony, so that we haven't specifically studied that in really in a detailed manner. However, we know that PEEP can decrease inspiratory effort, and this has been shown in animal models and in a few patients as well. It does not work in every patient, but there are some patients that respond very well to PEEP in terms of decreasing their amount of effort. The mechanisms for this, I would say, are two. So one is that when you have PEEP, so the diaphragm lowers, so it works in a less efficient position. So the effort the diaphragm performs for the same amount of drive is lower. Okay, so this would potentially correct desynchronies due to high effort. So mainly double triggering in the context of high drive and effort. The other mechanism might be if the patient is still potentially recruitable, having higher PEEP might improve recruitment, and then the stimulus coming from the lungs to the brain might decrease, and in this case also maybe drive might decrease, and then therefore effort, and all desynchrony is related to excessive drive and effort. And then related to COVID, so that's a tricky question. So there hasn't been a lot done in trying to understand why these patients have such high drive and effort, and also there hasn't been many studies really trying to describe in detail what these patients drive and effort. But from clinical practice, we all see that these patients have very high drive and effort normally. Then the other specific thing about COVID patients is that we normally need, clinicians normally provide a lot of sedation in the initial phase. So then when they, when they come out of sedation, when we start stopping that, they have a lot of cumulative drugs in their body. So their breathing pattern is really abnormal due to their underlying disease plus all the amount of effort the patient, drugs that the patient receive. So managing desynchronies in this transition phase from full sedation to wakefulness might be tricky. So I would say be patient, really look at your waveforms, try to adjust the ventilator settings to keep the patients as synchronous as possible. And you might need to go slowly if the asynchronous are really injurious. There's also the option that it hasn't been described actually, but of using proportional modes of ventilation, which might solve some of the issues relating mainly to timing and of desynchronies, when desynchronies are really related to timing. And then the other issue that would help a lot is to prevent over assistance. So if the patient's control of breathing is working relatively well, and when you use proportional modes, really it's very difficult to over assist the patient, because if the patient's drive and effort decrease, then the amount of support would decrease, and so the patients are not over ventilated, and then allows the patient's own control of breathing to work in a more physiological manner. I don't
Wonderful.
know.
No, I think that there's maybe one other question. Thank you everyone for attending. Just so that you all know, I know that probably people are trying to get back to, taking care of patients and working. So information about the CE will come in a couple of hours, and the recording of this presentation will be available in 2 to 3 weeks. And information will be sent out to all of you guys regarding the link for that. Dr. Elias, thank you so much for taking the time to answer some of these questions. And one final question, with all the variety of ventilators that are currently on the market, is there something or a graphic screen resolution that's required for seeing some of these, what seem to be small differences in asynchrony that seem to have a large effect?
So it's easier sometimes when when the screens do not auto-adjust the scale. So I think servo ventilators on Hamilton, there's some of them they're auto-adjusting, so that makes it a little bit more tricky to see the small desynchronies, mainly ineffective efforts. So if you're able to adjust the scale yourself, this might be easier. The other very important thing that ventilators do, so this you need to learn from whatever ventilator you have, is that they will tell you if the breath was triggered by the patient or the ventilator. So this is really, really crucial for detecting reverse triggering and distinguishing double cycling due to reverse triggering versus double cycling in the context of high drive and effort. So you have to look at the first insufflation from the two breaths. So you look at the first one and you check if that was triggered by the patient or the ventilator. And all ventilators will tell you that. Some, they will change the color in the trigger phase. Others, they will tell you if it was like a little lung or a little letter saying if this was triggered or it was a mandatory breath. If the first breath is mandatory and the second is triggered by the patient, then this is reverse triggering. If the first breath is triggered by the patient and the second breath is also triggered by the patient, this is double cycling due to high drive and effort. Okay, so I think that's a very important thing that the ventilators can help us with detection of asynchronies. It would be very nice if they would also tell us what asynchrony is, but I know you're all fantastic clinicians and you will be able to detect them at the bedside.
Yes, thank you so much, Dr. Elias, and thank you all so much for attending. Please check out our website to find out more information about other education that's available to you all through PACE here at Medtronic. And I just want to thank Dr. Elias once again and Dr. Burchard for making the time to give this presentation. And with that, I will leave you all to go back to your clinical practice. So appreciate all your time. Thank you so much.
Bye. Thank you.